All right. We're going to get started in 1 minute.
Huh? No. It's a class I got.
If you're on Zoom, just please mute yourselves. If you're not muted already. How you doing, Allie? I'm happy to hear it. All right, guys. Welcome. For those on Zoom, the audio might not be that clear, but I am recording on different microphones, so I can add it in on the recording after. But welcome. You guys are here for a CPAP and, in general, respiratory refresher, or CME. We are going to be starting to carry CPAP on our ambulances. It's going to be looking like this. And until we get a bag that's big enough to suit it, it's going to be located in the airway cabinet, and email will go out with all the details once it gets on there. So tonight we're going to learn, in general, what kind of patients would qualify for CPAP, who you should be using it on, and how we're going to use it, and everyone will get a chance to use it hands-on. All right, so like I said, tonight's objectives. So tonight's objectives is to discuss the respiratory system. We're going to do a little bit of a refresher on that. We're also going to look at the differences between respiratory distress and respiratory failure, the pathology of respiratory distress and common respiratory illnesses, as well as a mechanism of action on how CPAP functions. And then we're going to discuss the application and function of CPAP. So first, we're going to start with the respiratory system, right? So the respiratory system, as we probably all know, starts at the nose and ends in the lungs. From EMT school, we understand that's a vast array of various tubes that go down smaller and smaller and smaller until we reach the alveoli in deep into the lungs. In the airway, it's broken down from two parts. We're in the upper airway and the lower airway. The upper airway, like we said before, starts at the nose and ends in the trachea. The nose functions as a filter and a hydrator. The hair and the mucus in our nose catches any particulates or things along those lines, as well as the moisture that's in our nose. Helps moisturize the air that we're breathing in, keeps everything nice and moist for the lungs because our lungs don't like dry. All right. After it passes through the nose, over here it goes down the throat, it goes through the larynx, which is our voice box. It's how we actually speak. It's how I'm speaking to you guys. And then we enter the lower airway. So the lower airway is going to start after the at the beginning of the trachea and ends in the alveoli. The fibrous trachea, fibrous just means hard. So the trachea is made up of these rings, sort of like a vacuum cleaner. If you guys have ever looked at a vacuum cleaner hose, there's always these metal rings around it. And that's the reason that it keeps it open. So it maintains its own structure, because if you guys were to think about a tube such as your esophagus or your intestines or even your nostril that's flexible, when a pressure gets applied and you guys cover one nostril, suck in, you notice that your nostril collapses at that moment. If there was any sort of obstruction above the trachea and you guys were to breathe in, it would collapse your windpipe, and that won't be very beneficial. So that's why it's nice and hard. It keeps it open. After the trachea, you guys go down into the bronchus, to the bronchioles, the left and right, into the alveoli, which circulate into the blood, right? In the alveoli, oxygen goes in and carbon dioxide exits. Our respiratory system in general relies on a negative pressure system. Anyone know what a negative pressure system is? Right? So what happens is we're not getting air forced into our body, right, from the outside. What happens is the external environment is at the same temperature as our internal environment, until our diaphragm, which is over here pictured in red, goes downward, which expands the volume of our chest cavity, which in turn means that all this empty space that was over here needs to be filled, and in turn we suck in air. Like we said before, if this was our body system and our trachea was nice and flexible, every time we take a breath, our trachea would collapse, because we only are breathing in through two small holes above to fill these two massive 2-liter lungs, right? So the air always follows from high pressure to low pressure. And yeah, that's pretty much how we were to breathe. An important thing to note about this is the interpleural space over here. And yeah. All right, so what is respiratory distress? So the telltale definition of respiratory distress is when a person is unable to regulate gas exchange. This can cause them to either take in too little oxygen or expel too little carbon dioxide, and it could be for various reasons. It could be something physical in the way, like an object logged in the throat, or it can also be the death of lung tissue, or metabolic, like sickle cell anemia. The red blood cells are in awkward shape, or there's not enough red blood cells to transport oxygen. And another common physical barrier that we're going to talk about is bronchospasm or fluid. All right, so first there's respiratory failure. So respiratory failure usually follows respiratory distress, and this causes more severe difficulty. This definition is more severe difficulties with gas exchange. If this is left untreated, it could be fatal. So your respiratory distress person could be someone who just ran a marathon and they're tired and they're breathing heavy. Okay, that's respiratory distress. Respiratory distress doesn't always follow death. Respiratory failure does. It's something that's irreversible unless interventions are taken. All right, there's two types of respiratory failure, this type 1 and type 2. Type 1 is going to be a person who has low oxygen levels in their blood, so low SpO2, but normal or low carbon dioxide levels in their blood, which is the waste product of oxygen, of air exchange. And type 2 patients have low oxygen levels as well, but high carbon dioxide levels in their blood. So what are these two differences we said? It was low CO2 and high CO2, right? Why is high CO2 bad? Anybody? Medic? Right, so CO2 is an acid. All right, so the buildup of CO2 in the blood causes a burning sensation. That's why if you ever have one of those typical panic attacks, right, who just breathe and we're hyperventilating for about 10, 15 minutes until you calm them down, they start to have aching in their joints, right, some headaches and things along those lines, because there was such a buildup of CO2, right, because they were breathing so fast that they weren't expelling CO2. Their SpO2 is going to be fantastic. It's going to be 100% because they're breathing in all the oxygen in the world. The thing that's wrong with them is they're not expelling CO2, and that building up eventually caused them to pass out, which is the body's self-corrective measure. All right. So a little flowchart on distress to failure. This is a little bit of a comparison. So respiratory distress, their airway is going to be open and no support is going to be needed. They're going to be tachypnic, so they're breathing heavy or fast. They're going to have increased effort. Their lung sounds could be clear, could not be clear. They're going to be tachycardic because usually they're panicking. They're going to be agitated, which could also be due to AMS from it, and they're going to be pale. Respiratory failure is going to be much worse, right? So it could be possibly obstructed either by fluid or bronchospasm or a physical object such as a candy. They're going to have slower breathing because they're getting tired. They're going to have little to no respiratory effort, abnormal lung sounds, bradycardia, which is the heart's response to low oxygen is bradycardia. They're going to fail to respond if respond at all, and they're going to be cyanotic. All right, what's cyanotic? Yeah. So respiratory distress is usually considered that the person's still maintaining their own respiratory effort and airway. They're usually speaking in a few words per sentence. They don't have cyanosis and have good vital signs with tachycardia. Respiratory failure patients are no longer really sustaining their own life. They decline quickly through the stage. They could be bradycardic, cyanotic, speaking in one-word sentences is speaking at all, and giving less and less respiratory effort after each breath that passes. And these are the critical patients that are going to lead to death. So common airway diseases. So we have asthma. Asthma is a condition where there are spasms in the bronchi of the lung. The physical constriction results in difficulty passing air through, and it could be from hyperactivity, dust, or other air conditions like changes in the season. COPD, chronic obstructive pulmonary disease, is a chronic disorder, like in the name, that results from other physical blockages. This could be from irritation to the lung tissue that causes inflammation over time, and the increased secretion of mucus. Right, so another physical barrier that's going to be there. CHF is the third one here, congestive heart failure. It's another chronic disease where there's a physical blockage, but this time the blockage, instead of being mucus, is more fluid. It's caused by the decreased cardiac output from the left side of the heart. That's causing pulmonary edema, which is edema in the lungs. Pedal edema, which is edema that occurs in the feet, is from the right side of the heart failure. But mainly what you're going to see with CHFers when they call 911 is going to be because they're not breathing well, which is from pulmonary edema, the left side of the heart. The three problems that are not actually respiratory problems, but affect the respiratory system are going to be anemia, which is just, in general, it's a low blood cell count. One of those blood cells is going to be red blood cells, which is those transport molecules of the blood. Sickle cell anemia, like we said before, is the red blood cell, which is supposed to be a circular, oval type of shape, is a sickle shape. So what that results in is less oxygen being carried by each blood cell. And anaphylaxis, we all know, an allergic reaction that starts to shut down the whole body in general, but specifically the respiratory system, very similar to an asthma attack. All right, so the way that we're going to find out what's going on is through lung sounds. So lung sounds are a great way to assess the lungs' functions and pathology, and you could really figure out a lot about what's going on with someone just based off their lung sounds. So we're going to try to get a good understanding of those. The main lung sounds that we're going to worry about are wheezes, stridor, rhonchi, crackles, rales, and absent lung sounds. All right, so wheezes. Wheezes are high or low pitched, and they're caused by the narrowing of the airway. They're seen in asthma, COPD, or anaphylaxis, and they are continuous, meaning they're going on throughout all the breathing. Like we said, they could have a high or low pitch sound based on how extensive the obstruction, much like a whistle. When you're whistling, the more narrow the obstruction, the higher the pitch. Usually they're during inspiration. If they are during expiration, we'll talk about that a little bit, but that means it's progressed further and it's making expiration more difficult. And that's usually bad because of the obstruction. There might be a prolonged expiratory phase because, like we said before, when you breathe in, it's an active process. When your diaphragm contracts, when you breathe out, it's a relaxing process. All you're doing is just relaxing lungs. There's higher pressure in the chest, lower pressure in the atmosphere, so the air leaves, right? Because we go from high to low. If you start having somebody who has a prolonged expiratory phase, it means that it's staying in the lungs because of that obstruction, and now they're going to have to start forcing air out. Expiratory phases should not be an active process. Our diaphragms are not built for that. Really quickly, we'll take a quick listen to some wheeze. So this, what we were hearing, is an expiratory wheeze. You guys heard clear lung sounds on the way in, right? And only the wheezing on the way out. All right, the next one we're going to talk about is stridor. Stridor is an upper airway. It's usually a high-pitched whistle sound in the upper airway. So it's heard during both the inspiratory and expiratory phase, and this is indicative of something like croup, epiglottitis, aspiration, or even choking. Usually you can hear this without a stethoscope, but if you put a stethoscope to the lower anterior ends of the neck, you would hear this as clear as day. And this is what it sounds like. So like asthma, this is very similar to asthma, except the only change is really going to be the location, right? Asthma is not going to be in the upper airway in the throat here. It's going to be in the lower airway. All right, the next is rhonchi. Rhonchi is a low-pitched sound that's in the large airways of the lower airway. They're continuous, like wheezing, and occur in both the inspiration and expiration. They could be found with COPDers, cystic fibrosis, CHF, or other secretion disorders. Basically, it's a narrowing of the airway that's, instead of due to inflammation like asthma, due to secretion such as fluid or thick mucus. So the sounds you hear is going to be air rushing past the thick mucus or fluid, resulting in a gurgling, rumbling, or snoring type sound. When it's light enough, coughing can help clear these out. And this is what Ronchi would sound like. All right, so that was more like a rumbling sound compared to the whistling that we heard before. The last is going to be, or second to last, is going to be crackles and rails. So fine crackles and coarse crackles are the two different types, and they're both considered rails. Fine crackles are lower pitch or lower sound than coarse crackles. You're not going to hear them as well. Coarse crackles are more of a bubbling sound and are much louder than fine crackles. The sounds are popping or cracking, almost like a wood burning in a fire pit. They're not always continuous. They could be intermittent based off where the fluid is present or where you're listening. Inspiratory and expiratory crackles is usually a sign of early chronic bronchitis, while inspiratory crackles can be indicative of late pneumonia, late CHF, and coarse crackles are usually indicative of severe pulmonary edema. So there's two. First, we'll listen to fine crackles. So it's really sort of like when you pour a bowl of Rice Krispies with some milk. It lets out a few pops, and that's pretty much it. Coarse crackles are much louder. It's a deeper sound. And so this sound is more what you're going to hear when you're dealing with a CHF or severe pulmonary edema. All right, an absent, very simply put, is you don't hear anything. And this is the most severe, right? If you're not hearing anything, it means there's no airflow. This can be due to, again, thick secretions or fluid that's building up. Gravity pulls everything down. So if the buildup is so severe in the alveoli and the lung tissue, it's all the way on the bottom, you might have absent lung sounds to the bases, which means that all of that lung is not getting any oxygen, it's not getting any air and passing that through our body. All right. Usually it's caused by CHF, like we said, because of the fluid. Gravity is going to fall to the lower part. So how can we solve these problems? Very simply put, there's two P's: position and pressure. Okay. Usually, and a lot of respiratory issues can be caused by just simply changing their position. Even if you lay on your back, just looking up to the sky, it's not a very comfortable position. Like our friend here, no patient really should ever be lying supine unless it's for a neck, back, or spinal issue. It's not a comfortable position to be in, even for someone who doesn't have any respiratory problems. Now add somebody who has a respiratory issue, and it's unmanageable, it's unbearable. So other times pressure can fix, and it pretty much could fix almost all of them. And I say almost because it's not always the case. So pressure. So pressure ventilations can be provided via two methods. We have BVMs, which is more of an old-fashioned method. And now we're going to be introducing CPAP. When dealing with someone who's an unresponsive patient, BVM ventilations are almost always indicated. You'd also use a BVM for a flail chest segment. If you guys still remember that, what's the treatment for a flail chest segment? What was that? Right, positive airway pressure is the main point. Why? Since we just got a nice refresher on the airway. How? Elaborate. That's an easy answer.
Because the pressure vessel is comfortable.
Right. What is causing our lungs to open? We have the diaphragm, which pulls down, which opens the lungs, right? And it's attached to the lungs. The lung tissue is attached to the rib cage, right? So now we have a break in, it's two or more ribs in two or more places, right? So now there's this area which is no longer attached to the rest of the rib cage and no longer attached to the lung. So when you take that deep breath, there's no expansion, right? Because now your rib cage is expanding, but there's nothing attaching to the lungs to pull it open. Therefore, your lung is not expanding, you're not having any negative pressure, and you're not breathing. So that's why we provide positive airway pressure. But A lot of people think, okay, I'll use a CPAP for that, but that's not the case. It's not indicated. You'd still use BVM ventilations for that. So CPAP's goal is to keep the airway open with positive pressure. It's like forcing everything to dilate, like blowing up a balloon. So you're blowing up a balloon, everything dilates from that. It then keeps the airway open by providing continuous pressure. So when setting your pressure, we want to aim for about 5 to 10 millimeters of water, which we'll go over when we talk about the actual usage of the device. And that's always upon expiration. Just note that it's not the most comfortable to wear. As you guys can see, this is a giant mask. Someone who's already having difficulty breathing for, let's say, the first time or even the 7th time, doesn't want something over their face. So it's not a very easy thing to wear. And so people who feel claustrophobic might have difficulties with the mask. And since there's a constant pressure being provided, it's also a little bit more difficult to breathe out. And this is a picture of the device up close. All right, so it's really broken up into a few systems. We have the headpiece over here, the mask, and this is going to be your pressure gauge and what's providing the pressure. And this is just a filter that's filtering the air that's breathing out. Ours has a little green knob that we'll go over, and this is a red knob. The red knob is used to provide additional oxygen. So if, let's say, their oxygen saturations are still low with this, but they're getting good lung sounds now, so it's working, you could provide them more oxygen by hooking up an additional oxygen tank and just opening that to provide even more FiO2 is what it's called. And the green one is going to be used for a nebulizer, which we'll go over shortly. All right, so our indications for CPAP. So patients who would be candidates are usually in the moderate or respiratory distress to the respiratory failure scale. I know it's a large scale, but that's because really CPAP works for almost everybody. If you hear a lot of secretions that can't be cleared, like with a cough, like we were listening before, so you have a lot of wheezing, you have a lot of rales, you have a lot of rhonchi, and they're not clearing it by coughing. You guys think about it. Your positive airway pressure is going to force these secretions out of the way. It's going to provide a benefit. If you see a patient having muscle retractions, who knows what muscle retractions are? No. Accessory muscle usage is something else. That's more like nasal flaring or bending over. You see some more muscular action getting involved. Right? That's still a sign of respiratory distress and respiratory failure, but muscle retractions are a little bit different. We were talking about the vacuum hose before, right? It's being kept open. So what happens is if now there's a blockage in, let's say, the lower airway below the lungs, what's going to happen when somebody is now breathing in and there's that blockage up top, like the nose, it's going to shrink, right? So the neck muscles around the trachea, because the trachea, like if you guys take your vacuum hose tonight, when you go home, turn it on, cover the end so that you get the seal and it sucks your hand, you're going to see that the tube, it doesn't just stay open, it does kink a little bit because there's that increased pressure. The same thing is going to happen with your neck muscles, your trachea. So you're going to see their neck muscles around their trachea go inward because of that kinking of the tube. Again, that's a very late stage of respiratory distress. If someone has that, it means that they're getting very, very tired and they're probably not going to be breathing for much longer. If you see a patient having those muscle retractions, they're really tired and they're not going to be breathing much longer. Tiredness with breathing is a later stage. These are the types of patients that are about to code. 1 to 3 word sentences are an earlier stage of respiratory failure. And if the non-rebreather is not working, you can always go to CPAP. So like I said, we have moderate respiratory distress to respiratory failure, pulmonary edema or other secretions, muscle retractions, low SpO2, tiredness with breathing, 1 to 3 word sentences, cyanosis, again, more of a late stage. Absent lung sounds or rales, and especially the absent lung sounds, again, late, very, very late stage. And most importantly, no improvement with the non-rebreather. If somebody's not improving with the non-rebreather, they're only going to be declining. So prior medical histories that would benefit from CPAP, our main ones are going to be the CHFers, COPD, and pneumonia. Near drownings are on here as well. If you do pull someone out of a water, near drowning is someone who was pulled out of a water. Drowning is that they went into cardiac arrest. So if someone's pulled out of the water and they're conscious, but they said that they breathed in water, what usually follows after that is laryngospasm or bronchospasm. So you can prevent that by putting on CPAP and having that pass through the water so that the airway doesn't get too irritated. But CHF and COPD patients are going to be the typical patients that benefit from CPAP. Some patients have sleep apnea. Who knows what sleep apnea is? right? So what do they use when they go to sleep? BiPAP or commonly CPAP. BiPAP is more of a hospital thing. I don't want to get into what BiPAP is, but it's just two pressures. So it's inspiratory pressure and expiratory pressure. You're forgiven.
Thank you.
So what it does is it helps them sleep because sleep apnea is where they stop breathing during the sleep, usually caused by obesity and a tongue getting in the way. So CPAP, what it does is it's providing that positive pressure, which is keeping the tongue out of the way of the airway and keeping them breathing through the night. Your near drowning patients taking a lot of water can have a broncho or laryngospasm later on. CPAP can help prevent those symptoms. Asthmatics are a little bit tricky, right? Anyone know why? So what's the main issue with asthma? What was it? So the bronchoconstriction. I mean, it's happening in the upper end of the airway, right? Okay, we'll think about this. I still have you for like another 3 hours, right? So asthmatics have this bronchoconstriction up above, okay? When they take air in, they're wheezing, and then they're breathing out. We spoke a little bit about prolonged expiratory phase, right? How do asthmatics die? What do they die from? Does anyone have any idea? Any guesses? Too much CO? Any other answers? Little oxygen? Is that an answer? Anyone? Who says little oxygen? It was what? Not exactly. I mean, any medics. What do you give an asthmatic? Anything else? Those late stage asthmatics. Steroids are, I'm not talking about anything that's going to dilate anything or even get rid of the secretions. What? No. You guys are going on the wrong path. Very, very simple. It's fluids. Why? So what's happening is asthmatics, they don't really have an issue getting air in. The main problem with asthmatics is they're not getting air out, right? They're doing what's called auto peeping. Peep is...
It's like when you blow into a balloon and that first breath getting that balloon to open up.
So PEEP in a lung sense. So when you're giving bag valve ventilations, there's what's called a PEEP valve. PEEP valves restrict the air that comes out. So sort of like what these asthmatics are doing, because like we said before, expiration is not an active process, it's a passive process. So what's supposed to happen is when I take a deep breath, I suck the air in, and when I breathe out, I stop my diaphragm, right? So my diaphragm relaxes and everything comes out. Thank God. When you have that restriction in the bronchioles now, there's no letting that air out, but they still need to breathe, so they take another breath. So they're building up the CO, right? But that's not what ends up killing them, right? It's the increasing pressure that's going on in their chest. And what else is in our chest? Our heart. So the increased pressure around our lungs and building up in the chest also puts a lot of pressure on our heart, and they end up going into cardiac arrest and dying because of hypoperfusion. Their heart stops pumping enough through. So asthmatics are for that reason they're a little tricky. The main problem with asthmatics is that they're not always that they're getting air in. It's getting the air out, and this is due to bronchospasms not allowing the air out and having them to force the air out, which, like we said before, is not a very good process, and our body's not made for that. And so you can hear this with grunting, right? And eventually they stop grunting. And when you have to work to breathe out, you don't last long. You tire very quickly. And since the problem is air leaving, CPAP might not always help. And that's why we want to monitor the blood pressure wisely. All right. And so some contraindications of CPAP are pediatrics under 12, not for any specific reason, just because that mask won't fit on their face and we don't have the pediatric sizes. It's as simple as that. If there is a pediatric size, you can use it. But we just don't have the pediatric sizes for them to use. And typically it's under 12, but use your best judgment. If the mask can fit on their face, they can be considered an adult. So the patient being unconscious or unable to follow commands means that they're not going to be maintaining their own airway. Therefore, they're not a candidate for CPAP. Apnea, you have to be able to spontaneously breathe in, but most importantly, spontaneously breathe out to use CPAP, or else it will just keep forcing air in and nothing's going to leave, which is not productive. A pneumothorax, what's a pneumothorax? So a definition of a pneumothorax is a collapsed lung. There's various causes that can include spontaneous and traumatic, but one common cause I should say is a pulmonary bleb. Who knows what that is? it's a little weak spot, as we call it, as if like you look at a leather seat that's been left in the sun, there's going to be like this little bubble, or it's like rubber that's left in the sun. If anyone's a lifeguard, those lifeguard tubes left in the sun, they always have these bubbles that form on them. That's sort of like a bleb. It's a weak spot in the rubber, or the lung tissue in this case, that can eventually pop, which results in air leaving the lung and entering the chest cavity. And is that good for our negative pressure system? Now creating a pressure that's going to be equal to the outside. It's not. The lung won't expand. It's going to fill with air, and that air, because it has to take up space, much like a balloon, is going to compress on the lungs and the heart. And so CPAP will just continuously push air into that. That's not going to work. So that's why we usually say when you're dealing with COPDers, because they're very prone, or not very, I should say, but they are prone to these pulmonary blebs, to use it with caution. Make sure you listen to their lung sounds. Make sure that they're not having absent lung sounds on one side, which is going to be your very telltale definition of a pneumothorax, is that they start to have absent lung sounds on one side. And if that's the case, remove the CPAP. All right. Another is low blood pressure. Why? We just spoke about it. Right now, this positive pressure, much like what you're doing with the auto peeping of an asthmatic, is putting increased pressure on the chest and the lungs, which is in turn going to put pressure on what? Our heart, our superior and inferior vena cavas, which brings blood back to the heart. With less blood going to the heart, less blood leaves, which results in less cardiac output. Mouth or nose injuries or deformities, right? If something's broken in their nose and they're bleeding, or a tooth is broken, we don't want to be forcing air into that, because it's just going to push everything into the lungs. Facial bone or jaw deformities, mainly due to the seal. If a bone is broken, you're not going to be able to get a good seal. Uncontrolled vomiting, I think that goes without saying. If somebody vomits in this mask, it's going to go right into their lungs and they're going to aspirate. Or most importantly, it's making them worse. And this does happen, right? As paramedics, back in the day, if you talk to any old paramedic before CPAP was a thing, because CPAP used to take about 25 liters per minute of oxygen. And it was like you were using 3 tanks on one mask. Now it's great. They made a device that only uses about 6 to 8, so less than a non-rebreather. Prior to this, paramedics were saying they're intubating people all the time. Intubating is when you stick a breathing tube into their lungs. So they were intubating people all the time because of respiratory failure, and there wasn't a great way to manage it, right? Because if someone who's in respiratory failure or borderline respiratory failure going into that kind of irreversible state, a non-rebreather is not going to work for them, because they're not breathing on their own. So they would have to wait for them to pass out, bag them for a little, and then stick a tube into their throat. Now, one of the worst parts about intubation is that, number one, you're sedated, and you're kept sedated, because I don't think anyone wants to sit here with a tube down their throat. But it's very difficult to get them off, right? And so a lot of people, and the body shuts down, and it says, all right, I have something breathing for me. I don't need to do it on my own. And they become what's called vent dependent, and they stay on those for the rest of their lives. So we don't want to intubate people if we don't need to. And so CPAP has been the device that, once it came out, intubations dropped significantly, right? Because now we're giving somebody an out, or a reversibility to those respiratory failures, or those late stage respiratory failures. But it's not always going to work. All right, in my own experience, I put it on a patient, he got worse and worse and worse, even with it on, added more oxygen, still got worse. And eventually we had to let him know we're going to put him to sleep and we're going to stick a tube into his throat. And thank God he is still alive, at least last time I checked. All right, if it's not working though, take it off. You're not being productive. Put him on a non-rebreather and advanced life support. All right. So really quickly, just to go over the main operations of it, applying the CPAP. First, supply oxygen to the device. Don't put the device on a patient with no oxygen flowing. That's not going to help their claustrophobia and their trust in you, because they're going to start breathing into a bag, and they're not going to be happy about that. And once you lose trust with a patient, as you guys may have learned already, you never gain it back. After you supply oxygen to the device at the lowest liters per minute, don't pump it up to 25. In each of these bags, you guys will get to see, there's a little paper with a chart on it on how much liters per minute results in how many millimeters of water, typically. You're then going to hold the mask against the face. We're not just going to slap it on them and strap it on. We're just going to hold it, okay? And we're going to have them take a few breaths, about for 1 minute to 2 minutes. Make sure that they're compliant with it. Make sure they're comfortable with it. Sometimes you'll have to take it off and reapply it. And while you're holding it against, make sure you check for any leaks. You shouldn't hear any whistling. You shouldn't feel any air. You shouldn't see their hair blowing in the wind. It means you're not being productive, right? You need to have a complete seal around this. And then after that, you're going to adjust the liters per minute to start getting that 5 to 10 millimeters of water, which there is a pressure gauge, which we'll show you. And after you are sure that they're compliant, they're using it well, their stats might even start coming up and they're looking better, secure it to the face, and then you're going to monitor and reassess. All right. With the nebulizer, you're going to do the same steps, except there's a couple deviations. So you're going to supply oxygen to the device at the lowest liter per minute on the guide sheet. You're going to attach a nebulizer between the mask and the blue regulator, which we'll talk about. You're going to hold the mask against the face just like you were before, adjusting the liters per minute. Just keep in mind there is a change in the amount of liters per minute while you're using the nebulizer, since you're now taking 6 liters per minute for the nebulizer to work. After you're sure they're compliant, secure it to their face, and then attach the oxygen tubing to the neb on the green tab, which we'll look at shortly. All right, and then you're going to monitor and reassess and make sure it's working. So in summary, listen to lung sounds and understand what's going on. Really build an understanding for it and imagine while you're listening, what am I listening to and what's in the way? Secretions, if you hear them, or fluids, you can easily push them out with this type of device. You can have them cough a few times beforehand. That's also fine. See if they can clear it themselves. But when in doubt, use CPAP. It's very, very rarely going to hurt somebody unless they are already hypotensive, which you guys wouldn't do because you took a blood pressure before getting to this point. And CPAP, like we said, can always be removed, but it can't always be placed, right? A patient's not going to tell you, I'm going to pass out before they pass out, right? They're going to be breathing, and then the next second they're not, and at that point, it's too late to apply CPAP. So always put it on when in doubt, because you can always remove it later. All right, any questions?
No, I actually have one question. If we apply it as BLS, does ALS have to come along or no?
It's a BLS skill. If you do apply it, they are respiratory distress or failure, they should be coming.
Right.
Although some Rockland paramedics won't. But it would be a strong, I would QA the chart and I'd flag it for that, yes. Any other questions?
I had a medic tell me that I can't use it. I have with a student, but they told me that I shouldn't have used it because my patient's blood pressure was like 170 over 100. He said that the same with the pressure putting it on like a hypotensive patient, it can do the opposite and make it raise even more if someone's blood pressure is already high. So I didn't question him when he said that, but
So we didn't really touch on it much, but pulmonary edema, in addition to being caused by CHF, can be caused by high blood pressure, right? So once your blood pressure shoots up and up and up, increased pressure in your veins is going to go into the alveoli, and pressure takes the path of least resistance, right? And the alveoli are very thick cell walls compared to your thick veins over here. So what you're going to start to do is that blood is going to start to get pushed into the alveoli due to high blood pressure. There is no better candidate for CPAP at that point than those types of patients because you're helping with the blood pressure. CPAP never raises blood pressure unless they're agitated, but there's absolutely zero way it can cause blood pressure physically.
that's what I thought. That's why I put on my patient, and then I wasn't going to say anything in front of the patient, but you shouldn't turn on.
No, I think they may have just been confused. Yeah. I can't think of a possible way it would, unless they were so agitated that they started freaking out and throwing things and ripping it off their face. What? What country do they practice in? Any other questions? These are all very good questions. All right. So what we'll do now is each of you guys can take a look at the device, and we're going to start applying it and going through that step-by-step process. Okay.